This video demonstrates endovascular repair of ascending aortic saccular aneurysm in a 78-year-old female who presented with a 4.1 cm ascending aortic aneurysm thought to be secondary to penetrating aortic ulcer. She complained of chest pain on arrival and has an active diagnosis of pancreatic cancer. She was deemed a poor open surgical candidate. CT angiogram of the chest demonstrated a 4.1 cm ascending aortic saccular aneurysm. This was secondary to a penetrating aortic ulcer. Demonstrated here is this ascending aortic saccular aneurysm. We began our procedure by gaining access to the right internal jugular vein using a mini-stick needle, wire, and micropuncture sheath. We then upsized to a 7 French sheath and introduced a temporary pacemaker wire in the right ventricle, and this was connected for rapid ventricular pacing. Next, the left common femoral artery was accessed under ultrasound guidance using a mini-stick needle followed by the wire and micropuncture sheath. We then upsized to a 5 French sheath over a Benson wire. This was followed by introduction of a marker pigtail catheter into the ascending aorta just above the coronaries. We then gain access to the right axillary artery after performing a right axillary cut down. A mini-stick needle, wire, and micropuncture sheath was then introduced. This was followed by introduction of a Benson wire in the left ventricle. Once this Benson wire was introduced in the left ventricle, a catheter was introduced over this wire in the ventricle. A coronary angiogram was performed delineating the anatomy of the coronary vessel and the sinotubular junction. A super stiff Lundquist wire was then introduced in the left ventricle over a catheter. This was done to introduce a larger 18 French sheath through the right axillary artery access site. Patient was heparinized. Shown here is the introduction of the right axillary artery 18 French sheath. The fiduciary markers demonstrated on this screen are made possible secondary to fusion of the fluoroscopic images to the preoperative CT angiogram reference to bony landmarks. The top three smaller circles to the left of the screen demonstrate aortic arch vessels. The yellow circle demonstrates origin of aortic arch. The green circle in the middle demonstrates the location of the saccular aneurysm, and the purple circles denotes the sinotubular junction. The smaller red and blue circle underneath the purple circle denotes right and left coronary arteries, and the three small star marks denote aortic annulus. Once the sheath is introduced through the right axillary access site, a 36 mm aortic cuff is then brought in place and placed just above the origin of the coronary arteries at the level of the sinotubular junction and deployed. Prior to the deployment of stent grafts, rapid ventricular pacing is achieved through the temporarily inserted pacemaker wires in the right ventricle. This is followed by introduction of another cuff measuring 36 mm and deployed in an overlapping fashion. It extended from the middle of the previous cuff to the origin of the aortic arch. A completion angiogram is then performed demonstrating successful deployment of aortic cuffs to exclude the aortic saccular aneurysm. It also demonstrates deployment just at the level of the sinotubular junction without compromising blood flow to the coronary arteries.